the system was actually prioritizing how to get rid of this pandemic. Obviously, it was our first concern, but now we have to think about other comorbidities too. And we know that maximum death has happened in patients with diabetes and hypertension when they come to COVID as well. And there is a very efficient program happening in Kerala, and we believe that it will do more restriction in a more aggressive manner so that more people will be getting benefit of the program, as Dr. Bibin has rightly pointed out. And thank you for making us read and understand about hypertension and diabetes again. And I will be taking you through. We have 2 days allotted for this, so I thought we will see what is the importance of hypertension, what is the importance of blood pressure recording. We know that this is a blood pressure recording is we have learned even at our undergraduate stage days, even from first year and second year MBBS. But this is the examination that we very not actually with the same seriousness we have been doing it, because this is something we know for quite some time. So I'll take you through some of the important aspects of blood pressure recording and blood pressure monitoring. And tomorrow we will discuss more about the treatment aspects of hypertension. So this is uh, I just put it because whenever we talk of diabetes, we talk of diabetes, obesity, and hypertension all go together, and we need to address it together and we need to manage it together. So, this way only we can prevent the most important comorbidities. Most important complications, as already highlighted, like stroke, heart failure, myocardial infarction, renal diseases, and all those things that we really encounter with diabetes and hypertension. So today our focus will be on hypertension. So we know that some of the statistics already been told and estimated. This is the world statistics for the pharmacological treatment of hypertension in adults, WHO 2021. There are 1.4 billion people worldwide have high blood pressure, but just 14% have it under control. So we can imagine this is true for the entire globe, and it's not very different in most of the places and most of the districts or states in India as well. So we need to emphasize this importance of understanding and controlling blood pressure. And we know that cost-effective treatment options do exist. The drugs available to us, even in our own clinics, in our own hospital, we can use it uh, we can understand and use it timely and appropriately. The initiation is also important and titration is also important. And we can have cost-effective options for control of blood pressure. And Bibin has already told it is the number one killer all over the world. And India, this compounds the fact that hypertension is largely undiagnosed, untreated, or undertreated. So most of the patients, even if they have detected high blood pressure, they don't come for treatment. And even if they come for treatment, it is an irregular treatment. And what is actually we are aiming at for getting the blood pressure control, it is obviously not achieving in majority of the patient in India with hypertension. So we need to remember that high blood pressure is estimated to be the leading risk for death in the world, and we should become the world leader in prevention, early detection, treatment, and control of high blood pressure, also for preventing complications and for reducing cost of treatment. So our aim, especially from a government or a point of view, our aim is primarily to detect early, to treat early, and to keep it under control, primarily to prevent complications, and it should be doing it at a cost effective manner. So that is our primary aim when we decide controlling blood pressure, especially the silent killer. It is having so much of complications with uncontrolled hypertension. So we need to, these are the aims that we are actually remembering when we discuss about high blood pressure. And we know that it was in May 17th, and they have very clearly emphasized the need for measure your blood pressure, control, and live longer. So this is a very important slide. So I thought I'll just put it. This gives what all the things we will be emphasizing. Whenever a patient comes to us with a routine assessment and we do the blood pressure and we know that the blood pressure is high, we write down BP is 160 by 100. But at that point, we should look what are the things that we can modify in this patient even before jumping into treatment. So we can emphasize on all these points: reduce salt consumption, healthy diet, smoking, maintain healthy weight, daily exercise, limit alcohol consumption. All these points are actually very relevant when we discuss about hypertension, and it is not just recording blood pressure, writing an antihypertensive drug for that particular patient. And this is the other important point that we cannot remember, we cannot forget, and we need to emphasize that we are doing it the way correctly. So this is also very important whenever we record the blood pressure. The patient should be sitting straight. We should use a validated blood pressure apparatus, and we should be looking at all those. Patient should be comfortably seated, arm should be supported on a armrest, and back should be properly supported. We should use the ideal cuff size. Feet should be supported, legs should not be crossing, and all these points are to be emphasized whenever we think of blood pressure monitoring. So we have to see that we are doing it in the correct way of blood pressure recording. That is also is to be emphasized before we start managing on the hypertension. So recording is very important whenever we discuss about the blood pressure. And cuff size, this is also a major challenge. Whenever an obese patient comes to the clinic, we find it very difficult to record the blood pressure. We don't have the adult appropriate side cuff because if the cuffs just give away when we inflate the cuff. So this is also another important point we should be thinking about, because obese people do come. So we need to have a larger size of cuff also in the clinic so that we can appropriately measure the blood pressure. So it has to be an office-based measurement. That is what we usually do. So we have to make the patient comfortably seated, no smoking, no tobacco, no coffee, and the patient has to be properly seated. And we need to measure the blood pressure at least twice, and we need to take the average. Some of the guidelines say you measure at least twice two blood pressure we have to take, and we have to take it as the average blood pressure, and we have to document whenever we measure the blood pressure. That is the office-based BP measurement. But we know that we have many other ways that we can document blood pressure. That is automated office blood pressure monitoring, where the blood pressure, either it could be supervised or non-supervised, and the BP monitoring will be done. So patient will be in a separate room, so patient will not feel the office environment whenever we record the blood pressure, and it is supposed to be more accurate than the purely office-based blood pressure measurement. As we have been talking about self-monitoring of blood glucose, home blood pressure monitoring is also coming in a big way. Why it is important? We have seen its importance during COVID. We know that most of the patients, as they do the self-monitoring of blood glucose, they were doing the home blood pressure monitoring. So we have to ensure that they get the blood pressure recording from the home. This will help us for identifying people at risk, people are having high blood pressure, or those who are on treatment, whether they are under control or not. Whenever we talk of home blood pressure monitoring, we can ask them to get at least 2 readings or 3 readings, minimum of 2 readings, one in the morning, one in the evening. And patient can give us all the 7 days reading, and we can discard the first and second days or first day and take the average of the other days. So that will give a better assessment of the blood pressure than what we do as a single recording in the clinic. So this is the other more relevant change that is happening nowadays. Home blood pressure monitoring is coming in a big way. The other important change is happening is ambulatory blood pressure monitoring. Whenever we have a doubt whether this is a isolated increase in office blood pressure, whether it is the white coat hypertension as we call it, we can go for an ambulatory blood pressure monitoring. In an ambulatory blood pressure monitoring, we record the blood pressure from the connected BP machine every 15 to 20 minutes during day and maybe 30 to 60 minutes during sleep. So we have a continuous recording. As we have discussed about continuous glucose monitoring, we will get a continuous recording of the blood pressure. So this will give us an idea whether it is actually a white coat hypertension, or it is a masked hypertension, or it is a hypertension not under control. All those relevant things will we get from the ambulatory blood pressure monitoring. And the other important point, we know that whenever there is a discrepancy more than 15 millimeters of mercury, this can happen especially when there is a peripheral arterial disease, or as we have seen in subclavian steel, there may be a difference between right and left arms. Now, whenever we have a situation where there are two different values from both the arms, in that situation, it is said that we need to take the higher value whenever we record the blood pressure. And other important point, especially in elderly, whenever we get the blood pressure recorder, we should not forget about postural hypotension, especially when the vessels are calcified and we increase the antihypertensive medications without actually seeing the patient and seeing only the blood pressure. Patient may develop postural hypotension, and we know that the postural hypotension is nothing but a systolic BP fall of 20 and a diastolic 10 from the supine to standing position. And in an elderly, especially with other comorbidities like diabetes, this may be very troublesome for the patient, and patient may fall or injure, and all those things can happen. So this is not just about a single value of blood pressure, but it is about the whole patient that we are treating, and this point has to be emphasized whenever we think about hypertension management, and we should know what are the ways that we can record blood pressure. And this is also about the instruments that we use for blood pressure. We know that slowly there is a concern about the mercury as a toxin, and there may be a slowly evading of the mercury sphygmomanometer. So the other sphygmomanometer like electronic or an aero, all those apparatus might come, and it is also equally good if but we know that every BP apparatus needs a validation, and we should find out what is the way of getting the BP apparatus validated in our place. So that is also needed whenever we record the blood pressure. So the machine should be properly kept, and the patient should be properly addressed, and the patient needs should be addressed, and we should be doing or recording the blood pressure very properly as per the description. Then only we will get the correct reading. And we know that there are other methods also other than the conventional office blood pressure measurement, like out of hospital blood pressure measurement, home blood pressure measurement, or ambulatory blood pressure measurement. All these things are coming up whenever we discuss about hypertension. And hypertension definition, I don't have to emphasize. We know that a systolic BP more than or equal to 140 and a diastolic BP more than or equal to 90 millimeters of mercury, which is equivalent to 24-hour ambulatory blood pressure monitoring, that is less than 130 by 80. Home blood pressure monitoring average less than 135 by 85 millimeters of mercury. So it is better that we know also these cutoffs. Whenever a patient comes with multiple home recorded blood pressure, we can see that if the blood pressure recording is more than 135 by 85, in a home blood pressure recording, we can consider it as hypertension. So this is from the evidences of multiple RCTs. And the classification of blood pressure, we don't change the cutoffs, whether the patient is younger, middle-aged, or older people. But there are challenges in recording blood pressure in children, and the values are different in children, which we are not discussing in this presentation. So in the absence of end organ damage, that means patient has come with a high blood pressure, single value, the diagnosis of hypertension should not be made until the BP has been measured on at least 3 visits, spaced over a period of 1 week or more. So we should not be starting treatment with one single value, provided there are no end organ damage. But if there is evidence of end organ damage, even with a high single blood pressure of reading, we need to start treatment in these patients. So this is what I have been discussed already. So we can see that a normal blood pressure is 120 by 80, and an abnormal blood pressure is 140 by 90. And if it is more than 160 by 100, we need to be careful. So 130 by 80, this range, the second value will come to the pre-hypertension, that where we need to address the patients about the control of the preventive measures like weight control, diet control, physical activity, all those advices we can say. I have put this slide just to show you that what is normal with regard to clinic blood pressure, home blood pressure monitoring, ambulatory blood pressure monitoring, and we see that there is a nighttime drop in ambulatory blood pressure monitoring, and in fact this drop actually saves the patient from the development of complications. So this is a 24-hour ambulatory blood pressure monitoring. So we need to know in the clinic the normal is 120 by 80, any value more than 140 by 90 is hypertension. So this is also I have emphasized where we do the continuous 24-hour ambulatory blood pressure when there is a suspected episodic hypertension, like pheochromocytoma. The patient says at one point the BP is very high, but whenever we record the blood pressure remains, so there is an episodic hypertension. And sometimes we need to know whether it is actually the therapeutic response. Patient's blood pressure is under control at some times, or like there is another situation, we call it as white coat effect. That means the patient is already on treatment, but whenever we see the blood pressure is actually high. But at home, in the home blood pressure monitoring, like the white coat hypertension, there is a white coat effect. This happens on patients who are taking treatment for hypertension. And sometimes patients taking antihypertensive medications, all our readings are within normal limits, but patient says hypotensive symptoms. Resistant hypertension, 3 or more drugs and the blood on the maximum tolerated doses. One of them is a diuretic, but still blood pressure is not under control. Autonomic dysfunction, postural giddiness, postural hypotension, and suspected mask hypertension. All these things, our single home blood office blood pressure may not be adequate or accurate, and we can go for ambulatory blood pressure monitoring, but even if we don't have ambulatory blood pressure monitoring, it may not be available for us. But I have just introduced the concept because we need to know this. This might be available for us also as a cheaper alternative, so we should be knowing it. But if we are not very sure it is available, we can go for multiple home blood pressures recordings at home, that is home blood pressure monitoring. So definition of hypertension according to office, ambulatory, home blood pressure level as per guideline statements. So you can see current guidelines also says how do you diagnose hypertension. This is the clinic values. We know that this is the Indian guidelines on hypertension 2019. BP is more than or equal to 140 by 90. This is the same as CSC, European Society of Cardiology, European Society of Hypertension Guidelines 2018. This is the American College of Cardiology, American Heart Association Guidelines. So we know that as per Indian guidelines also, more than or equal to 140 by 90 is hypertension. Home blood pressure monitoring. Patient does multiple blood pressure values at home and comes to us. Then the value more than 135 by 85, we need to call it as hypertension. If the patient had an ambulatory blood pressure, 24 to 48 hours blood pressure patient has got an nominal average of 5 to 7 days reading, we can see that usually we do for a single day ambulatory blood pressure monitoring. So daytime ABPM more than or equal to 135 by 85. Nighttime ambulatory blood pressure more than 120 by 70, we consider it as blood pressure. Okay, so we need to know that these are the cutoffs. More than what we usually say that one office blood pressure, this is hypertension. Another important concept in hypertension management is dipping. Dipping means proportional decrease in nighttime compared with the daytime blood pressure. We know that there is a fall in or dip in blood pressure during nighttime. So that protects from the development of many of the adverse cardiovascular event. How much dip that happens is approximately 15% lower than the daytime value in both normotensive and hypertensive patients. That means even in hypertensive patient, there is a nocturnal dip or drop in blood pressure during nighttime. So this failure of the blood pressure to fall by at least 10% during night or during sleep is called non-dipping. So non-dippers have got a higher cardiovascular risk than dippers. So non-dipping is a risk factor for cardiovascular complications. So this is the ambulatory blood pressure monitoring. You can see that this is the measurement. This is the normal ambulatory blood pressure. This is the systolic blood pressure, and this is the diastolic blood pressure. We can see that there is a 10% dip during night time. This is the midnight reading. So there is an obviously a dip during night time, and this is known as the dippers. This is the normal dipping of blood pressure. This is a continuous 24-hour ambulatory blood pressure monitoring, and we can see that there is no dip as we see in this patient, in a normal patient. So this is a patient, this is with hypertension, and there is no dipping. So these are known as non-dippers, and this is also considered as a cardiovascular risk. Non-dipping is a cardiovascular risk. Okay. And another point, this is something we have all experienced. It's a cuff inflation hypertension. We repeatedly inflate the cuff. There is a marked rise in blood pressure caused by cuff inflation during self-measurement. So patient repeatedly does it, and the value increase even after each recording, and patient becomes very much anxious. And this is also thought to be because of the cuff inflation pressure as well as the effort that patient puts in inflating the cuff. So this is also associated with anticipatory anxiety. So we need to comfort the patient, and we need to do it in different occasions, and we need to tell them that this is actually not true blood pressure. We have to be comforted and told. So whenever we discuss about hypertension, we need to know what are the different names that we are going to hear about hypertension. We know that there is normotension, that is blood pressure less than or equal to 120 by 80 millimeters of mercury. Sustained hypertension, blood pressure more than 140 by 90 millimeters of mercury. And controlled hypertension, patient on treatment and blood pressure is under control. Sustained uncontrolled hypertension, every time blood pressure is uncontrolled and patient is on medication. White coat hypertension means patient is having high blood pressure only in our clinic. When the patient goes home, there is no hypertension. That is known as white coat hypertension. And white coat hypertension also in some studies shown as a cardiovascular risk than a normal blood pressure in the office. So we have to advise them to reduce the stress and other things, and we can advise them in lifestyle modification even in white coat hypertension. And white coat effect is a person who is taking normal treatment and blood pressure is under control at home, but whenever he comes to our clinic, the BP shoots up. This also happens when a patient goes for a procedure. BP is well controlled, but when the patient goes to the theater or patient goes for the anesthesia checkup, the BP goes up. So this is known as the white coat effect. And masked uncontrolled hypertension. Masked hypertension is another term that we should understand. This is something, the BP is always controlled within the office environment, but whenever the patient goes home, whenever the patient is not in the clinic-based testing, always the BP, this is known as masked hypertension, and this is also described in cardiovascular diabetes and in patients with renal disease. Because of some of the implications, this masked hypertension is also relevant. Masked uncontrolled hypertension, patient on treatment, but the masked blood pressure goes high whenever the patient is not out of office. So all these things we have to understand, because it is not the single value that we are recording. This is the total control of blood pressure, the total burden of systolic blood pressure as well as the diastolic blood pressure that the patient is exposed to. That is more important, and we need to see the patient as a whole. That is the point I would like to emphasize whenever we record blood pressure. And when we move to risk factors for primary or essential hypertension, I don't want to emphasize, this is something we see every day, but it is just revising so that we should not forget all these important. Age itself is a risk factor. As age advances, there is a risk of developing blood pressure. Obesity, family history, race. Black race is supposed to have a higher propensity for blood pressure. Reduced nephron number, low birth weight, high sodium intake, excessive alcohol consumption, and physical inactivity. So whenever we say that moderate consumption is protective, we emphasize that high consumption is adversely affecting. It is a known risk factor for hypertension. So we need to reduce, or we need to stop alcohol consumption. That should be the message that we are giving. Somehow we are giving the message that moderate consumption is beneficial, but it's not for people who are having an excessive alcohol consumption. They need to reduce the amount of alcohol that they are taking. And whenever we see patients, we see for the risk factors, we see we think that it is primary hypertension, but always we have to be on the look of treatable causes of blood pressure, high blood pressure, which is otherwise known as secondary hypertension. That is hypertension due to a single identifiable cause, which may be treatable with an intervention specific to the cause. So we need to have a high index of suspicion, and early detection of secondary causes of hypertension is also important whenever we talk of high blood pressure. What are the findings suggestive of secondary hypertension? We have a patient in front of us and we have identified high blood pressure. We have started treating the patient, but we know that the blood pressure is not getting under control. We are adding with single drug, we have moved to combination therapy, we have added the diuretic, maximum tolerated dose, still BP is not getting controlled. This is otherwise known as resistant hypertension. Patient with hypokalemia, that is potassium level less than 3 milliequivalents per liter, we need to be careful. We are managing, we are treating a case, we are seeing a case of secondary hypertension. Elevated serum creatinine level, obviously we will be testing for renal function test and potassium at least one value at extremes of age, where we think that this could be something other than the primary hypertension. Definitely we need to look these values, and it's always preferable to see in all patients at least once whenever starting treatment of these patients with hypertension, so that we will not miss renal diseases and things like that. And strong family history of kidney disease. And there are many other things for where hypertension may be a factor or associated factor, like endocrine diseases and all those things, hyperthyroid, hypothyroid, all those things we need to be on the lookout, so that we will not miss treatable causes, which will take care of to some extent the hypertension, and the other part only we need to. So this might convert a resistant hypertension to treatable hypertension. Another important thing we must ask whenever we see a patient with hypertension is, we must ask for what are the drugs the patient is on. We should not forget about it, because many of the drugs are available over the counter. They don't need any prescriptions for a drug. So we must ask prescribed and not prescribed, which the patient goes and get from the counter, so medical shops that patient gets. So this list is also very oral contraceptives, NSAIDs, and yeah, many of the antidepressants, corticosteroids, decongestants, sodium containing antacids, and illicit drug use. All these are important whenever we control a patient, whenever we approach a patient with high blood pressure or hypertension. Pseudohypertension, when the arterial media becomes severely rigid from calcific stenosis. We know that the patient's vessels feel like a pipe, rigid pipe, and it will be rolling on under our fingers. So this is known as calcific atherosclerosis. And in that patient, whatever pressure we apply, the vessels will not collapse, and we will not get a reading of the blood pressure. We will not get a reading systolic blood pressure or diastolic blood pressure, and we may be increasing the drug without seeing or without recognizing this. And in an elderly, they may start getting symptoms of postural hypotension or BP fall. So we have to ask, they may be having other concomitant history of atherosclerotic disease, chronic kidney disease, diabetes mellitus. So we have to be very careful in those situations. And actually in this situation, an ankle brachial index, which we see for peripheral arterial disease and diabetic foot, if we could access to it, is an ABI more than 1.4 is suggesting the possibility of the presence of non-compressible arteries. So we should look for other things, target organ damage, all those things must be looked into in those patients whenever they complain of posterior giddiness or the other factors, especially in elderly. And pseudo-resistant hypertension. When we treat hypertension, we do our best. We advise the diet, we advise the exercise, we do the treatment, and we monitor the lab parameters, but still blood pressure is not getting under control. So poor adherence to prescribed medicines. Patient may not be taking the drug. You have given the good prescription, you have given the drug, but patient is very irregular. The adherence part is very poor as far as the patient is considered. So sometimes we can ask the patient to bring back the drugs. The adherence may be not due to patient have many other factors. Patient may not be remembering the tablets, all those things. So we should be having some way of making them remember to take at the time that we prescribe the drug. So that is one important. White coat phenomenon, that this patient is on treatment, blood pressure is well controlled at home, but whenever he comes to us, whenever he sees the doctor, the blood pressure goes high. Poor office BP measurement technique, that is also an important factor. So we should be making sure that the blood pressure instrument is well maintained in our clinic. And I have already told about brachial artery calcification and clinician inertia. We also have to put the enough effort to make the patient involved in the treatment and involved into the dietary and exercise modifications that we suggest. So we have to be part of the treatment team rather than just somebody records the blood pressure, somebody brings the results, somebody dispenses the treatment. We just put the treatment in the card. That is not going to work. We have to ask what are the problems, what are the challenges, whether the patient is actually taking the drug. All these are very important whenever we advise with regard to hypertension. Other important point I wanted to emphasize: women with pre-existing hypertension during pregnancy. So hypertension in pregnancy is a very important entity, and we should be seeing that all women, before going to plan pregnancy, we should be make sure that they don't have hypertension, they don't have undiagnosed diabetes. And we may be seeing women with pre-existing hypertension during pregnancy. So they can continue their antihypertensive medications, but we must see that AC inhibitors, ARB, direct renin inhibitors, not nowadays very much available or used, are contraindicated due to adverse fetal and neonatal outcomes. And when a young female comes to us for hypertension treatment, though our guidelines say it is always, we know that ACA inhibitors, ARBs are the first choice in most of the situations. In a pregnant, when a woman planning to conceive, planning to become pregnant, we should never start ACE inhibitors and ARBs. Methyl dopa, labetalol, calcium channel blockers, these are the drugs of choice in such women. And beta blockers are also not a very good choice, especially atenolol, because they may induce fetal bradycardia and the fetal growth may be affected. So we have to be very careful in initiating treatment in women with hypertension, because it is a separate situation that we are dealing with. And we may feel terribly sad when the patient comes in the first trimester and somebody has already started the patient on AC inhibitors and ARBs for a casual recording of high blood pressure without thinking too much on that prescription. So we have to be very, very careful when we prescribe treatment in women, and we should have more details at regard to the history and other things. We must be very careful about this. And in a pregnant woman, we are a bit reluctant to start diuretic therapy also, but there are appropriate indications where we can start diuretic therapy in patients with pregnant women. So we have to be very careful when prescribing drugs in women with hypertension. Pharmacological treatment of hypertension in pregnancy. So this is what I have already emphasized. There are clear contraindications for drugs during pregnancy. AC inhibitors, ARBs, mineralocorticoid receptor antagonists like spironolactone should not be prescribed in women with planning pregnancy or in the first trimester or during pregnancy, especially mostly during first trimester, because of the fetal anti-androgen effects. Beta blocker atenolol due to the observation of intrauterine fetal growth inhibition. So whenever we prescribe an antihypertensive drug in a woman, take more into the details whether she's planning pregnancy or she's already become pregnant. So those things we must be, because it is a very one casual prescription from our side may be may do harm to that person. So we have to be very careful for women with hypertension, especially during the reproductive age group. We have to take more details with regard to the history. Now we are moving on to the complications of hypertension. I don't have to elaborate. We know that it's a heart related to heart, nervous system, and kidneys. LVH, heart failure, ischemic stroke, intracerebral hemorrhage, heart actually LVH, heart failure and ischemic heart disease, nervous system, ischemic stroke and intracerebral bleeds, and CKD, end stage renal disease in kidneys. So these are the non-complications and well-known recognized complications of hypertension, and even public is very much aware of this, and that is why they try to get a blood pressure recorded at every point wherever they go, but they don't bother about it, making it under control. It is a silent killer. Dr. Bibin was emphasizing the term silent killer, and we have been using it again and again. Why? Because it causes asymptomatic organ damage. So this knowledge is very important. I will put one or two case histories just to make it just aware that it is a silent killer. This was a 30-year-old male. He was having an asymptomatic high blood pressure, but he was never bothered to treat. And he became symptomatic only after developing chronic kidney disease. And in fact, this patient was very rapidly deteriorating and he had a transplant. And later, he developed more complications and other things and transplant failure because he had a hepatitis C infection and lots sorts of complications. But when we felt very sad because on looking back to the history, and looking back to the case records the patient was carrying, there were very many points. The patient was recorded blood pressure more than 180, 100, 180, 120, 180, 110. And this patient was moving with this, and patient was going from one doctor to other doctor just because patient doesn't want to initiate medication. So this is not for one patient, but this is a very common history. I've just put it for as the case that we have seen for single patients, but we all might have seen such cases in plenty. And this is another patient. He was working in Gulf and he came back, 35-year-old male. He came just because he had high blood pressure, uncontrolled blood pressure. That is why he came to me. But it's not for the blood pressure that he came. He came for the visual impairment. There was a gradual loss of vision, unilateral, more on the right side. So he was thinking it is due to his high blood pressure, and that is why he came from the return from the Middle East for seeing the clinic. So he has shown us he had having high blood pressure, but interestingly there was high uncontrolled diabetes too. He has been documented high blood pressure many occasions. He has prescribed drugs. Sometimes he will take, sometimes he will not. And he has visual impairment. And on examination, he had a unilateral right neovascular glaucoma. So, and there was total carotid occlusion on the right side and 70% on the left side. So this is a very young patient. There were very many treatable causes, risk factors for him identified, but he presented very late. So such sort of presentations are very, very common. I put two case histories just to make us again think that it could be a silent killer. This person, if we don't record the blood pressure and we don't advise him the correct treatment, and we should emphasize them, patient goes from one doctor to the other doctor, thinking that somebody will tell, and if we say that we will check the blood pressure again, he will go to the next doctor. So this way he is moving from one person to other person and never getting the proper treatment. Why? Because there are benefits of lowering blood pressure. Various studies, stroke incidence is decreased, myocardial infarction, heart failure. So we need to know that this is a silent killer. We need to record blood pressure. We need to look for comorbidities. We need to look for whether there are any target organ damage. So there is a big responsibility. It's not just recording single value of blood pressure. So we have to prevent target organ damage. That is the sole aim of this documentation of blood pressure and treating blood pressure. So this message has to be very clearly transferred to the patient. Then only they will come to the way that we want to them continue the treatment, that they should not skip the treatment because they don't have any symptoms. Then why should they take treatment? Obvious question that they are going to ask. What is this target organ damage? It is the structural or functional changes in arteries or end organs, that is heart, blood pressure, brain, eyes, and kidney, caused by an elevated blood pressure and is a marker of preclinical or asymptomatic cardiovascular disease, which hypertension is a marker of preclinical or asymptomatic cardiovascular disease. And severe or long-standing hypertension can also be found in less severe hypertension. So mild hypertension, whether I should treat or can I go with the diet? Yes, you can go with the diet and lifestyle modification, but we cannot wait so long if it is not controlled. We have to make sure that the patient comes into the treatment category rather than just going into lifestyle modification. So whenever we have a patient coming to us with hypertension, there should be a basic screening for hypertension mediated organ dysfunction is performed in all hypertensive patients. So we need to see whether there is a urine albuminuria, is there any casts in urine, what is the blood urea, what is the serum creatinine, what is the serum potassium, has he got diabetes, all those things, some basic investigations. Is there any polycythemia? Is he obese? Is there any obstructive sleep apnea? All these things will affect his blood pressure. All these things will modify his treatment. All this will modify the advice that we give for that particular patient. So it is not single reading, it is not single diagnosis, or it is not antihypertensive drug alone. We have to reclassify the risk. A patient with heart failure is not the same as a patient coming with no organs affected. So we have to reclassify the risk, and we need to tell them very clearly why we are prescribing drug to them. So it might influence the selection of drug treatment of hypertension as well. If the patient has got cardiac failure, we will be putting him on diuretic. If the patient has got a renal involvement or albuminuria, we will prefer of ACE and or ARVs. So like that, if the patient has got a myocardial angina or cardiac myocardial dysfunction, all those things, we may be starting on in beta blockers. So this has to be emphasized. So we have been talking about what is blood pressure, what are the cutoffs, how do we measure, what are the different types of hypertension measurement like ambulatory blood pressure, home blood pressure, office blood pressure, all those things we have seen. And when we diagnose hypertension with all these cutoffs, and what is the relevance of treating hypertension, why it is called silent killer, what are the target organ damage, and now we move on to the blood pressure control. It is the most important modifiable risk factor for coronary heart disease, stroke, peripheral artery disease, and stage renal disease, congestive heart failure. The higher the blood pressure, the greater the risk. Barriers to blood pressure control. Patient management time constraints. When most of the time we practice alone, or the clinician sees the patient, and we don't get enough time. So we need to have a nurse, or we need to have a dietitian or somebody else with us, so that they can take part of the responsibility of properly advising the patient, so that we, and even the pharmacist can be of help. So we have to incorporate everyone, pharmacist, nurse, or the dietitian, or the advisor, or whoever is there. They can put them into the team. And depending upon where we practice, depending upon a smaller center or a higher center, we can build up the team so that our time constraints can be addressed to a larger extent. So this is what I have meant by physician practice patterns we need to modify. And we need to tell them whenever we prescribe a drug, the common belief is the drug is causing the complication, the drug is causing the target organ damage. So we have to tell what are the adverse effects of drug. Most of the patients stop AC inhibitors or ARV for a single cough, thinking that this drug is the cause for cough. And they say that I know that this drug can cause cough. So we must tell what is a cough in AC inhibitors or ARV, when we should stop. So they should not be telling too much about the common side effects, and we should take them, understand the problems, where we should be treating. But if the patient on ACARB, we are seeing that the potassium is rising, obviously we will stop, or we will stop and we'll change the drug. So, and also we have to address the patient specific factors. All these barriers are to be understood. And so most of the time, the most important barrier why they are not adhering to the treatment is they think that these drugs are causing the problem. They don't need to control a disease where there is no symptoms. So they will come for control only when they develop problems due to the high blood pressure. So there is a behavioral factor. This is a major role in increasing control of blood pressure. So we have to advise them. And now we move on to the dietary management. About 30% related to increased salt consumption. So we need to advise on low sodium intake. So we will move, we'll discuss about sodium chloride a little bit. But the other important behavioral factor, physical inactivity, obesity, excess alcohol consumption causes hypertension, and being tobacco free is especially important for people with hypertension. So we need to advise on the behavioral factors. We should understand why this patient is reluctant to come for treatment, or reluctant to continue or adhere to the medicines that we prescribe. Secondly, we need to address all these behavioral factors: physical inactivity, obesity, excess alcohol consumption, no tobacco or tobacco free. All these are important. And now we move on to the diet, salt concepts. We know that the person has to restrict the salt. That is 1 teaspoon salt per day. One packet in our market contains, if we think that this is 1 kg, And one sachet, maybe 500 is also available. One sachet we can get it at 0.5 gram or 0.75 gram. 0.5 gram sachet is 200 milligram of sodium, and 75 sachet contains 300 milligrams of sodium. And 1 teaspoon is 2300 milligrams of sodium or 5 grams of sodium chloride. And if we restrict, usually we say that they have to reduce all the table things that they add, puppets, pickles, as well as added sodium, all those we ask them to reduce. And processed food, fast foods, and added salts. And we need to tell how much sodium, how much salt they are getting into the house, and how much they are using, and how much time they are using. The way they can be made aware how much sodium is using in their home as such. And reducing sodium has gone the most important intervention which actually reduces the blood pressure. So we need to tell them the correct way that they can understand. So the recommendation is WHO recommendation, and Indian guideline on hypertension 2019 recommendation is all less than 5 gram per day. That is 1 teaspoon sodium chloride per day. So we have to tell them what they should take, and we should tell them which are the food that contain lower salt and which are the food that contain higher salt. So this is about 100 grams. 100 grams, this is amla, bitter gourd, bottle gourd, all those things. All these vegetables has got very low sodium, and these are the ones that have moderate sodium, and these are the ones that have moderately high sodium, and this is more than 100 milligrams. This is a very high sodium content. So they have to be told which are the ones that is lesser sodium containing vegetables, and we have to give them some options so that they can be also part of reducing the salt intake. And we should tell that it should be reduced as much as possible, and the guidelines say we have to reduce less than 1 teaspoon, that is 5 gram. Why we have to emphasize on salt? Reduction in salt intake can delay and potentially prevent the onset of hypertension. And we know that BP rises with age. Approximately 90% of adults eventually become hypertensive as age advances. So dietary sodium reduction blunts the age-related rise in BP. Hypertensives have a greater BP reduction in response to a decrease in sodium intake compared with non-hypertensives. Respond to antihypertensive drug better. We can even tell them, if you reduce the sodium intake, if you reduce the sodium chloride intake, we can reduce the medicines that we prescribe, number of tablets we prescribe, and it also the age-related increase in blood pressure, that is also seem to be reduced if we really reduce sodium in our daily food. Why is it important? Because we can reduce the number of drugs, we can reduce the complications, and the investments in prevention are often cost saving. They don't have to get hospitalized for all those complications, and moderate sodium reduction has no adverse effects. So these points have to be very clearly told to the patients. And policy interventions also, because it is a cost saving and allow people to make healthy choices. We should be having to improve diet and physical activity, and people should have healthy choices so that they will use such a lesser sodium containing food. So we have been discussing about the non-pharmacological approaches in treatment or prevention of hypertension, that is reducing salt intake less than 5 gram daily, eating more food and fruits and vegetables, that is potassium containing food, being physically active on a regular basis, avoiding use of tobacco, reducing alcohol consumption, limiting the intake of foods high in saturated fats, and eliminating or reducing trans fats in, that is deep fried food items. So all these are the things that we advise them, and these are the things that should be displayed in any clinic that we practice, so that they can read it again and again, and they can incorporate into their dietary lifestyle interventions. So these are the lifestyle non-pharmacological approaches we should be advising to every patient with hypertension, and even the patient with pre-hypertension, or the person has got high risk of developing hypertension. So this is the way that we should be educating them, and we may not be getting adequate time, but we can put it in posters and other things so that patient will be more aware of these things that we can. So we can advise on reducing weight, increasing physical activity, moderate consumption of sodium, saturated fat and cholesterol, and adequate intake of potassium, calcium, magnesium. Avoid tobacco, avoid alcohol. All these are to be emphasized again and again. So So these are the foods that contain potassium. So this all the vegetable, all the some of the vegetables and the fruits we know. So these things they can include in their diet regularly, so that it will be more of potassium and less of salt, and that way they can modify the development. And these are the food substances that they should avoid: table salt, salt preserved food, pickles, ajinomoto, baking powder, fried foods, alcohol, bakery products, biscuits, canned food. All these are high salt containing food, and we need to tell them that they should avoid, because these are all available in plenty: potato chips, cheese, peanut butter, salted butter. The taste as such has changed over the years, and these are very widely used even in Kerala. So we have to tell them with each at every patient, rather than reducing salt, avoiding salted pickle and papad. It is should be going beyond that, so that patient will understand what we are telling to them. And dietary approaches to stop hypertension also says the same: whole grain cereals, fruits, vegetables, legumes, nuts, low fat dairy products, lean meat and fish, and low salt. Salt intake less than 2,300 milligram of sodium. That means 5 gram, which is 1 teaspoon of salt, not a tablespoon. Sorry. Avoid saturated and trans fats and added sugar in your diet. So, and also we tell them know your numbers. We need to have an early detection, treatment, and achieve the goal, self care. And we should put the immediate BP target. When the patient comes to us, we have made the diagnosis. We have tell them that you have hypertension. We have to start the treatment. We have spent time about the advice on pharmacological, non-pharmacological methods of hypertension, and we should put the target. Usually, we say that less than 130 by 18 high risk hypertension, that is high diabetes, cardiovascular, cerebrovascular, renal disease. But in most, less than 140 by 90. But in people like elderly, where there is postural hypertension or giddiness, we have to be more careful. And which drug, I think we will discuss about solely about drug tomorrow. So we will tell which are the selections, how do we go, what our guidelines say. But what the message I wanted to say from this slide is, when whatever antihypertensive drug that we use, the main benefits of antihypertensive treatment are due to lowering of blood pressure per se. So it's largely independent of the drugs employed, but we do select some drugs for in some select indications. But we must be very clear to the patient what is more important is the blood pressure and under control 24 hours of the day. That is more important than the drug. And I've already told the BP target less than 140 by 19 most, and less than 130 by 18 selected indications. But most of the patients are able to achieve the target that we are telling if we really put the treatment very correctly. But we must be emphasizing what are the target, and it is important to acknowledge that only 50% is reaching the target, and we are missing the opportunity to prevent a cardiovascular disease or a stroke in millions of people if we do not achieve the target whenever we treat the patient. So this 50%, if we could pour effort, they are under suboptimal control or due to various reasons. So we need to check at every point if the lifestyle intervention is appropriate, smoking, tobacco. Is there any drug that the patient is taking from the over the counter? What is the weight? It is appropriate. So all these points we need to re-emphasize, and we should try to achieve the blood pressure control rather than just up titrating the drug. That is the very important message. And this is the clinical inertia that I have been talking about. Many clinicians do not routinely assess blood pressure. This is a statement. I'm not telling who is not doing or who is doing. But this is a common belief. It may be wrong. I may be wrong. Many clinicians do not routinely assess blood pressure and do not initiate or titrate treatment in those with elevated blood pressure readings. It may be due to the patient's pestering that I will do it. I'll do the lifestyle modification. I will come next time. Patient may not come next time. Patient will go to the another doctor. So if there is a documented high blood pressure, we have to be more careful. So we have to have a self-criticism also at this point, so that we can be better clinicians. And most of the time, don't always believe what the patient says. We have to see what is actually behind in every prescription, in every reasons why it is not actually happening, we need to have a closer look at it. Have a closer look before making the advice or whatever choice we make. And for the healthcare professional, measure BP at all relevant clinical encounters, assess CV risk in those diagnosed with hypertension, treat those at high CV risk to control blood pressure level, assess hypertensive disorders of pregnancy, advocate for healthy public health policy, and encourage and assist community BP screening programs. So this is also very relevant, community BP screening programs. And BP reassessment. We have made the diagnosis, we have started treatment, we have ruled out secondary causes of hypertension. We know that this patient is having hypertension. So that patient will go for the treatment. But there is a group of patients who are having normal blood pressure. So in those situations, we need to have a reassessment every year. And in those with high risk, obesity, or other risk factors, we have to make them blood pressure recorded at least twice a year. Every 6 months, patient will come for a reassessment of blood pressure. Okay. So this is for the physician part, and for the individuals also, we should give them targets. We should tell them how to choose low sodium option, how to avoid extra salt, how to be physically active. All those points we should emphasize at every visit, even when we do the assessment. And we should know in patients more than 75 years older, or patient have postural giddiness, patients elderly, living alone, institutional, where we cannot have a regular monitoring, all those situations, we should have a less aggressive goal for blood pressure as well. And hypertension, hypertension urgency and emergency, we are not discussing, but we must understand severe hypertension with target organ damage is hypertension emergency, and severe hypertension no target organ damage is urgency. And we have guidelines. I'll just mention about the guidelines, and we will just see more about it tomorrow, how to treat it, how to control blood pressure. Okay. And I'll just mentioning about, these are the things we have already discussed. This is about the this is the guideline that has come up, that is the ACC/AHA guideline 2018-2017. It has also put all these definitions, and it has classified in stage 1, stage 2, and whatever we have told, the undiagnosed group is higher. There are risk factors, how to measure blood pressure, how to monitor blood pressure, and we need to have at least 2 measurements before putting a patient diagnosed with blood pressure. What are the things we will be doing when we evaluate the patient? And we should definitely look for the cardiovascular risks, and also look for identifiable causes like sleep apnea, drug-induced chronic kidney disease, primary aldosteronism, renovascular chronic steroid, pheochroma coagulation, thyroid, parathyroid. All these are very important. And look for target organ damage, which we have already told about: heart, brain, chronic kidney disease, peripheral arterial disease, retinopathy. And newly diagnosed hypertension, we should have the electrolyte, especially potassium, creatinine, blood glucose, urine, complete blood count like polycythemia and other things we have to, and thyroid stimulating TSH for ruling hypothyroidism, lipid profile, electrocardiogram, urine albumin creatinine ratio, and echo in selected indicated cases. So we need to know which are the investigations that we should be doing for hypertension. And treatment also, I have already emphasized about non-pharmacological lifestyle modification, annual monitoring. Even if the patient has no high blood pressure recorded, we should have an annual monitoring, and more close in those patients with high risk. These are the targets we have already discussed. And this is from the Indian guidelines on hypertension for 2019. There they have put optimal blood pressure, normal blood pressure, high normal blood pressure, and we can see that stage 1, stage 2, and stage 3 more than 180 and more than 110. So this is the difference from the earlier guideline. And isolated systolic hypertension, the systolic blood pressure is high, but the diastolic blood pressure is always less than 90. And this is the recent one that has come up, that is a guideline for the pharmacological treatment of hypertension in adults 2021. And we will be discussing about this, how to approach, which drug we will be using. Today, I have been primarily emphasizing what are the what is the importance of recording blood pressure? How do we record blood pressure? What are the ways we are going to manage blood pressure? How to choose the, how to diagnose blood pressure? What are the investigations we will be doing? How do we supposed to monitor? What are the risk factors? When do we suspect secondary hypertension? What are the reasons for not getting the adequate control of blood pressure? And we have also seen what is the importance of understanding hypertension in women, what is the difference than just prescribing a drug. So all those things I have been primarily emphasizing, and we will be talking about the guidelines. This is the state guidelines, all those things about drug we can talk tomorrow. This is just to refresh ourselves about more about the hypertension, understanding high blood pressure and other things. But definitely we can see about the drugs tomorrow, and we can plan in a better way management aspects tomorrow. Thank you.